Hello and welcome to Sleep is My Waking Passion, the podcast where we get real about sleep and how it shapes your life. I'm Dr. Allison Cole, a triple-boarded pulmonary critical care and sleep medicine physician who's learned to thrive despite having chronic insomnia. And now I'm here to help you do the same. Hello, everyone, and welcome to Season 7 of the Sleep is My Waking Passion podcast. I have with me a returning guest, Dr. Ruchir Patel, who I spoke with on last season's podcast, and we talked all about Zepbound and obstructive sleep apnea and the impact of that drug in that space, including weight loss. Dr. Patel, I should say shortly, is very talented, and he has a lot of experience in medical device as well. So I have been on this journey of learning a lot through him, and I wanted to share with you some of the things that I learned that he has done specifically in the implant space for both treatment of obstructive sleep apnea as well as central sleep apnea, which we do not talk a whole lot about on this show. So Dr. Patel, just by way of description here, I'm going to kind of abbreviate this, but if you want to hear his full intro, which is very in-depth, go back to that episode on season 6, okay? Because it's worth it. But he is essentially a board-certified sleep medicine physician. He's an entrepreneur. He's a consultant. He has over 15 years of experience in sleep medicine and neuromodulation. He actually founded a sleep medicine practice that has 3 locations. He has also been involved in all sorts of different things, including transcranial magnetic stimulation therapy. He was actively speaking for Zepbound as a speaker. He has done consulting work for a company called Zoll, which makes a product called Remede, which we're going to be talking about today. And more importantly, he will be joining the staff at Inspire, which is a company that manufactures a hypoglossal nerve stimulator treatment for obstructive sleep apnea, starting actually this Monday. So by the time this airs, it's going to be official. He is going to be Vice President, Senior Medical Director over at Inspire. Congratulations, Ruchir, and welcome back to the program. I'm so excited to be talking to you again today.
No, thanks, Allison. Thanks for that lovely introduction. I do have a lot going on, but yet I still focus on my wife and 6-year-old. But yeah, it's fun. We only live once, and we have to make the best of everything. So, but thanks. Lovely to be back again, and excited about talking about this morning. So.
It is so fun that we get to spend time with our kids and our family, and yet still get to do cool stuff, like nerd out on various sleep topics. So I mentioned a couple products, and people would be like, whoa, where's this conversation going? So let's start off with Inspire Therapy. Yeah. By the way, this program is sponsored by Inspire. So thank you very much for that sponsorship. It truly means the world to me that you believe in the mission of this labor of love that we call the Sleep is My Waking Passion podcast. So nod to you all. You may hear a commercial in between us speaking, just so you're aware for the audience. But so Ruchir, can you talk to me a little bit about Inspire Therapy? What exactly is hypoglossal nerve stimulation? And how is it an appropriate treatment for obstructive sleep apnea? What should we be thinking about when we hear this word Inspire? Because I'm sure a lot of people have seen some commercials on TV and are very curious about it.
Yeah, so Inspire, which is produced by Inspire Medical Systems, it was FDA approved in 2014 as a treatment for moderate to severe obstructive sleep apnea for individuals that are intolerant or can't use CPAP therapy, which is, of course, a gold standard therapy for obstructive sleep apnea for, I think nearly 35, 40 years now, right? And so it was FDA approved in 2014. In essence, I actually have a device here I can show you. This is Inspire 4. So this is, in essence, what the Inspire 4 device looks like. On May 12th, Inspire 5, which is a new generation implant, was officially released. But that's Inspire 4, which pretty much majority of all my patients currently have. But in essence, it looks like a little pacemaker, but it's placed by ENT generally between the second and third intercostal space. For Inspire 4, there's a little sense lead that's placed against a very superficial rib muscle, which detects breathing effort. And then there's a small little tunnel that's created, and then there's a small little 2-inch incision right here, just below the right jawline, That's where the nerve that controls the tongue, called the hypoglossal nerve, that's where it's located, and place a little rubber cuff that has 3 electrodes on it right around the distal branch of that nerve. In essence, what the device is doing, once you turn it on with the remote control, which is what most people have seen the ad on TV for, is a remote control. But when the device detects inspiration or when a person is inhaling, that's when the device then stimulates that nerve for basically 4 seconds. And by activating that nerve, it causes the tongue base to pull forward, and it also has a lifting effect on the soft palate as well. In essence, what it's designed to do is every time a person is inhaling, it's proactively opening the airway to prevent snoring and the collapse that would typically cause obstructive sleep apnea. It's a great device, and I'm saying this as a sleep physician, even outside of my role, with Inspire Medical Systems. I implemented it as a therapy about 6 years ago. Initially, I was trepidatious. I think, like most sleep physicians, we're not accustomed to surgery. And, many years ago, I think it was in 2010, right? Or before then, that upper airway surgery stopped being recommended as primary treatment for snoring and or obstructive sleep apnea. So we as a field have been training, all of us, and have trained that surgery doesn't really work. So I had that notion. I had met a patient in 2016 who was one of my patients, but he lived in Denver and lived here part-time, and I hadn't seen him for 18 months. And he came in for a follow-up visit and he had Inspire. I was like, whoa. And I was excited about it because that was my first case. I didn't know anything about it other than the literature and the New England Journal of Medicine, STAR trial paper. I got all the records from Colorado and was reading them, and it was ENT involved in managing, and he couldn't tolerate it. And at the lowest voltage of I never will forget this, 0.5 volts on plus minus plus, which is the out of the box settings, he had some difficulty. Now, mind you, this patient had a history of anxiety and had, some insomnia issues as well. And he just was an overall very anxious person. Even with CPAP, he struggled. At the time, I didn't really know how to manage Inspire, right? And I had never been exposed to it. So I suggested, how about we reduce the voltage, reduce the pressure on CPAP, and do combination therapy. And I never saw him again, right? So I don't think he liked the idea of doing both. But that was my initial exposure to Inspire. So from that standpoint, I had a difficult time even, suggesting. And I had patients that had slowly started hearing about it between 2016 and 19, asking about it as well. I only have one case that I've come across, and he really couldn't tolerate it. So I'm not really sure, I'm not really confident, if this is a right therapy. But then my first case in 2019 was a gentleman in his mid-60s with frontotemporal dementia. He had severe OSA. His AHI was in the mid-60s. And when he used his BiPAP device, his wife noted improvements in his cognition, but because of the frontotemporal dementia, he had difficulties remembering to put on the machine at night or the mask on at night. And his wife was now the only one working. So she had a vested interest both ways in terms of improving her sleep, but also improving her husband's cognition, quality of life, to treat the obstructive sleep apnea. So we worked together for a better part of 18 months to try to make, PAP therapy work. And it just boiled down to, he just would forget to put it on. When he put it on and wore it, it was perfect, right? His AHI was 0, his mass leak was really low, but couldn't get him to wear it every night because of his dementia. So I offered them Inspire, and they said, yeah. I said, okay. I said, I'm not really sure what else to do, but if you're open to it, let's try it. And long story short, activated him, did really well during this 90-day period, brought him into the sleep lab, slept for 8 hours straight. His AHI went from 63, I think it was, to 0 over 8 hours. And his average usage was about 8 hours per night. And I texted my local reps at the time, it's like, holy crap, this actually can work. I was shocked, right? And so that was my aha moment. I was like, wow, all right, well, maybe this actually can work. And he was very happy. His wife was happy. He was tolerating it, no issues.
So did he actually remember to turn it on, or was it that the wife was combination? Okay.
If he forgot to turn it on, his wife knew, and she would look at the remote and saw that the light was white on the remote. So she would then, click it on for him while he was asleep. So it was a combination, but it was easy because all she had to do is just lean over and turn on the Inspire implant with the remote control while he was asleep, and he slept through the night, right? So it was much easier than trying to
strap a mask on and all that. Yeah. That is very clever, actually. Very clever. Now, his response for the listener, sometimes when you're looking at any product that's not PAP therapy, we always look at what's considered to be efficacious. And he had essentially a complete response. But that's not always the case with Inspire. So can you kind of level set what can be considered to be a positive response or a good response with Inspire? You maybe, and I'm curious to see if maybe your perception is that we can get closer to resolution than what the literature suggests. But I know that there's some data behind the STAR trial and sort of perfection was not necessarily the end goal, but significant improvement was. And I was wondering if you could clarify that.
Yeah, I mean, so in the STAR trial, I believe the share 15 criteria was being used, right? Where the goal is to reduce the baseline AHI by at least 50% and AHI less than 15, which brings AHI down into the mild category. And that's how I operated in the beginning, because that's how I was taught, right, by Inspire in terms of this is what the goal is. Now, of course, as sleep specialists, we're accustomed to PAP therapy, being able to get the AHI less than 5 and normal is less than 5. And we have this mindset, pre-programmed mindset, truthfully, that's what normal is. And I was guilty of it. I was like, well, it was a kind of a sense of pride of, if I can get my PAP patients down to close to 0, why can't I do it with Inspire? Like, I understand there's a share of 15, but I want to get these people down to, less than 5. And I would say, like, right now, I have about 450 patients personally with Inspire, and my mean treatment AHI for about 300 of those, because the others I just haven't had time to input, but for about 300 patients, my mean treatment AHI is about 4.8 from a baseline of about 45, right? So my point in sharing this is that I have learned that you definitely can get disease resolution as defined by an AHI of less than 5 with Inspire. Now, was it by design, meaning that did I set out this mission? Initially, I did, but then after the first, I'd say 20 cases, I learned that there's a paradigm shift that must occur. And I'll give you an example, right? I've had many cases of Inspire patients where, their AHI reduced by at least 50%, was reduced to less than 15, so met the share 15 criteria, right? But their AHI was still around, say, 12 or 13 during the PSG. Now, during the PSG, the arousal index was normal, the quality of sleep was normal, there was no hypoxia, there was no snoring, and the patient was asymptomatic clinically. So from that standpoint, does that residual AHI of 12 actually mean anything at that point, right? And that's when I learned, like, well, actually, it doesn't, right? Because if the arousal index is normal, the quality of sleep is normal objectively, there is no hypoxia, and there's random 12 events per hour, but there's no snoring, the patient is doing well, and they're actually using therapy, right? Adherence is significantly higher with Inspire therapy than it ever has been with CPAP, right? Adherence is, upwards to 80% plus. My patients, I think over 80% are greater than equal 4 hours per night, right? We all know PAP therapy compliance at the end of 12 months is quite poor, but we know data from 36 months, about 46% of people will continue to use PAP therapy at 36 months. With Inspire, the adherence is very, very high, indicating that patients are happy with it, ease of use, and it's effective, right? There's symptom improvement. Otherwise, a patient wouldn't use therapy, even if it's convenient and easy to use. If they're not benefiting from it, the patient wouldn't use it, right? So these individuals are using it significantly. But getting back to the whole AHI is that's when I kind of learned that, okay, maybe I need to soften up what my approach is in terms of what do I consider to be a successful outcome with Inspire. I guess I don't have to chase after an AHI of less than 5, right? And even though we've been taught with Inspire that that's not the goal, or it doesn't have to be the goal, all of us in sleep, we've all been pre-programmed to think that is the goal, right? And if we don't get it, then the treatment wasn't successful. But you have to factor in all these other metrics as well. And when I started looking at the whole picture, and I bring all my patients into the lab because I want to look at all these things, right? In the event that if the AHI isn't less than 5, but it's less than 15, all right, well, were they still hypoxic? Were they still having disrupted sleep? If no, okay, well, then I'm happy to let this patient be with an AHI of, 12, 10, Because at that point, it doesn't mean anything. If the patient's asymptomatic clinically, there's no snoring, they're sleeping well, they're using therapy, and the data suggests from a PSG that, hey, things are good, then why chase after a number, right? It's like the cardinal rule of medicine that we're taught in medical school was like, look at the patient, not the number, right?
It's just a data point.
Yeah, it's just a data point.
That's such a great point.
Yeah, and I trained in Ireland where the focus was always the patient, not the numbers, right? When I was in medical school 20 years ago, like we had 2 MRI machines in the entire country of Ireland, right? And they were on opposite sides of the country. I'm not kidding you, opposite sides of the country. So I was trained with focus on the patient, listen to the patient, don't focus on the numbers. The numbers are important, but the most important is what the patient is telling you. So taking that conceptual framework from my training, that's when I was like, all right, we don't have to get it to an HI of less than 5, right? We have to take a look at the whole picture, including what the patient is saying. But now I did say, however, that, close to 300 patients of mine have an average AHI of 4.8. So you may be questioning, all right, well, in that notion, why do you have most of your patients in the normal range? Again, that was self-taught. It wasn't by design. It wasn't this mission. And what I mean by self-taught is that after I started my first 20, 30 cases, I started questioning, all right, what else can I do? How can I make this better? And I started just learning advanced programming, and I kind of taught myself. Inspire provided me tools on the care pathway, but then I started learning, kind of teaching myself, what are these different electric configurations? How does it change how the tongue is moving? How are patients reacting to it? So by virtue of learning and teaching myself these advanced, programming and utilizing all these other tools like awake endoscopy, dread-induced sleep endoscopy with Inspire, I've been able to get the AHI just naturally down to the normal range. And I'll give you an example. I have a patient from last night. She's an Inspire 5 patient. I'm part of the limited market release, my second one. She's the 4th patient that's been titrated now with this new generation implant. And it went from an AHI of about 35 to less than 5. And she is beyond happy. She told me on Tuesday when I saw her in clinic, she's 70 years old, lovely lady. She's a kindergarten teacher, and said, you have no idea how much you've changed my life with this. And I was like, well, I just kind of help guide you, but you're the one turning it on and off every day. But she's like, no, you have no idea. Like I have not slept like this in most of my adult life. I couldn't tolerate CPAP, and I'm waking up rested. I'm sleeping through the night. I'm happier. I'm actually better able to handle the kindergarten kids, and quality of life is just better, right? And it's cool. Like, it's a good feeling, right? And so many people have told me, I was requested a quote, this week, and I was like, I have had more people tell me that, hey, Dr. Patel, you've changed my life so much. You have no idea with Inspire compared to with CPAP therapy, right? So my point is that once a person learns how to do the advanced programming, in some of the cases, like majority of the cases, will have a great outcome, right? In terms of getting to an AHI in the mild category or even less than 5 without having to put in a lot of effort. But there are some other cases where you do have to think outside the box. And if you learn how to think outside the box, you actually can get really good outcomes with it. It's just a matter of putting in the effort and the dedication to do it. And one of the things that I did 3 years ago, I think I pivoted to just doing neuromodulation. So that's all I do in the sleep practices, Inspire cases and Remedy cases. And again, by giving that dedicated time, I was able to learn more and more and more. So
over the years, I've referred countless patients for Inspire therapy because it can be a total game changer for patients with moderate to severe obstructive sleep apnea, especially if they've struggled with CPAP. Inspire is an easy-to-use, mask-free solution that works inside your body, syncing with your natural breathing to keep your airway open while you sleep. Over 100,000 people trust Inspire for restful nights, and the new Inspire 5 system makes things even easier because it has an integrated respiratory sensor, and this means no separate sensing lead and a simpler procedure, and respiratory sensing right inside the implant. But here's why I really love it. 99.6% of Inspire procedures are completed without major complications. 93% of patients recommend it to family and friends. 91% say it's better than CPAP. And 90% of bed partners report no or just soft snoring. Plus, there's a 79% reduction in sleep apnea events. So if you're ready to wake up refreshed, please go and ask your doctor about Inspire or reach out to me because sleep is my waking passion.
So I want to hit pause for a second and just reiterate to the audience that the gravity with which I decided to do this second episode with Ruchir, I really thought about it because he really is a bit of a unicorn when it comes to sleep medicine practitioners. What I mean by that is I've had a number of cases with Inspire. The way my old practice was set up was that we had a number of sleep providers. We had one ENT. The ENT is wonderful. He was actually on a previous Inspire talk that I did on the show that you guys can reference back to. But when we were working together, the programmer that Ruchir is talking about is an investment, and it's not always financially viable depending on how the structure of the medical group is set up, so that we could really only afford one. So we decided, since there were all these other practitioners who were all referring to one person, that we're going to leave that on the onus of the ENT. That does leave a bit of a gap in the educational piece. And one, though, that I think is something that Ruchir, you being an addition to Inspire, I think is a real opportunity, because you kind of know what you need to do. And I think being able to maybe provide some of the guidelines, the instruction, or expand how we teach not only ENTs who are programming, but also the sleep providers who are programming, and extending that could only elevate the response rate to which we're going to see a good outcome for these obstructive sleep apnea patients.
Yeah, I'm glad that you brought that up, Allison, because I 100% agree with you in the sense of what I do and what I've done from a management standpoint. It's not rocket science, truthfully. It's just a matter of needing to understand that there's these other options available and how to do it, right? It's almost like vent management. Remember when we were internal medicine residents and we had our first month in the ICU and we're going to be expected to manage a vent? We're like, we buy the big ICU, right? The blue one. I still have it here on my shelf. But it's kind of like that, right? But physicians, to some degree, we all have an ego in the sense of we don't want to admit when we don't know something, especially as practicing physicians. So it's a bit of a balance in the sense of, I think sleep physicians need to make themselves a bit vulnerable to say, hey, I really do need help to learn truly how to manage this implant, versus Inspire also providing more tools and education to really help support the physicians. And that's one of the things I'm really passionate about, just because of what I've personally learned through my own patients in my own practice over the last 6 years. And I have the mentality of, if I don't know something, I won't just wait for someone to teach it to me. I'll just go after and try to figure it out on my own, because I get frustrated personally if I don't know how to do something and my patient is expecting me to do it, even if it's unrelated to patient care, even if something at home, like, replacing a faucet. I'll look at YouTube videos all day long and figure out how to do it, That's just my personality. But I think not everyone thinks that way. And as a result of it, that's one of the things that I'm helping in my new role with Inspire, is to be able to optimize education. Like what the team has done so far, we have a great foundation, great foundation of the care pathway, right? But knowing what I know, what I'm hearing from sleep physicians like yourself and others that I've spoken to, there's room to optimize it, right? And I think if we can improve on how we're educating, improve on the tools that we're providing sleep clinicians, I really do strongly believe that majority of sleep physicians, if not all of them, can actually have amazing outcomes with Inspire. Not that there aren't amazing outcomes, but I think all of us can have even better outcomes, right? And my outcomes are really good. I'm proud of them. And it's a lot just of, the things that I learned. So from that standpoint, it's like, if I can do it, and I'm not a rocket scientist, I think we can all do it, right? It's just a matter of providing those tools, right, and that education. So that is one of my missions.
I love it. So I want to switch gears a little bit and start to introduce what the heck Remede is, because it's even new in the sleep world. I recall, I think the first time I heard about it, I want to say it was about 3-ish years ago or so at an NYU sleep conference. And I was like, whoa, I didn't even know they were doing this. And I got very excited about it. It sounds like it's really appropriate for a very specific patient. I find it fascinating that you've actually had combination folks that have both Inspire as well as Remede. Yeah. So can you explain to people a little bit about, central sleep apnea, why someone could potentially benefit from this type of implanted device for that? What conditions that you're thinking about when you're even considering an implant like that?
Yeah, absolutely. So the Remede device was FDA approved in 2017 for moderate to severe central sleep apnea. And the indication is moderate to severe central sleep apnea, and the only contraindication is active infection. It is implanted by electrophysiology, which are the same cardiologists that implant pacemakers, because it's the same type of approach, right? So in essence, I don't have an example of the Remede device, but it's a little bit larger than the Inspire implant that I showed. But in essence, it's for individuals that have central sleep apnea. And central sleep apnea is a less common form of sleep apnea. It doesn't deal with the throat collapsing, snoring. It's actually associated with periodically the diaphragm just doesn't contract, right? So you don't make an effort to breathe while you're sleeping. And it's not because of an obstruction. It's just there's no movement of the diaphragm, which is the main muscle that helps us breathe while we're asleep, because all the other accessory muscles are, in essence, asleep. So the traditional treatment for central sleep apnea, based on our guidelines, is going to be either adaptive servoventilation therapy, as long as you don't have an ejection fraction less than 45%, or bilevel PAP ST, which is a very difficult machine for most patients to tolerate. I don't know what your experience has been with BiPAP with the backup rate, but mine has not been very good. But Remede is now a nice alternative for individuals that have central sleep apnea, that you don't actually have to even try PAP therapy to qualify for central sleep apnea. But in essence, what it is, it's a little pacemaker device, and it's placed on the right anterior chest wall, and it's a venous approach. So basically there's a stimulation lead that's inserted through the subclavian vein, and the most ideal location to place this lead is in the left pericardiophrenic vein, which runs adjacent to the left atrium and the left ventricle, and it runs very parallel to the phrenic nerve, right? In essence, the Remede implant is also known as a transvenous phrenic nerve stimulator. The phrenic nerve, there's a right and left. In essence, it stimulates each hemidiaphragm, and when the diaphragm contracts, that's what allows us to take a breath, and then we exhale. So in essence, the lead is ideally placed in the left pericardiophrenic vein. It is a very difficult vein to access because it's very narrow, and the entry point is tortuous, from what I understand. If we can get the lead into that left vein, awesome. If not, then the backup is going to be placing it into the right brachiocephalic vein, which runs parallel to the right phrenic nerve. It is a larger bore vein, so it's a coiled lead with 6 electrodes on it, but then it sits there, and we wait about 6 weeks before we activate, because we want the lead insertion site to heal, so there's no lead migration. But in essence, what the device is doing is that for the first 6 weeks after we activate, or after the device is implanted, it's in monitoring mode. So it's actually recording the individual's respiratory rate when they're asleep, their movement, sleep position. So it's collecting all this baseline data. So when we activate, we know that, all right, this patient's breathing an average breath of 12 breaths per minute, for example, when they're sleeping. So we need to make sure that we're, in essence, pacing and stimulating the phrenic nerve to ensure that they're breathing at 12 breaths per minute. The device is not... It's not like a true pacemaker where it kicks in when it hits a threshold. It's constantly stimulating. So the whole intent of the Remede device is that once we get it activated, once we know it's basically capturing the phrenic nerve, meaning that it's actually able to stimulate the phrenic nerve, then we are getting the output, so the voltage on the device, slowly titrate over the course of 3 months to a point where once the device is in therapy mode, the device is constantly stimulating the phrenic nerve to ensure the patient is always taking a full breath at 12 breaths per minute, or whatever their average respiratory rate is at night. And so if the brain, in essence, tries to stop sending a signal down the phrenic nerve to have the patient take a breath, it doesn't matter, because the Remede device is ensuring that the patient's always taking a breath. So that's how it's overcoming the central apnea. So it's not responding to the central apnea event. It's just basically constantly stimulating breathing all night long. So even if a central event tries to occur, doesn't matter. The Remede device is constantly stimulating the diaphragm to contract and give that patient a breath.
And how are patients tolerating it? Because it sounds like you're having some success there. It doesn't wake them up at all, or doesn't feel awkward to them?
It does in the beginning. Like, I have 40 patients with the Remede. I think we have 45 patients with Remede in the practice, but I've got majority of them. I'm like the 4th or 5th largest site in the U.S. with Remede cases. The very first one I did was really exciting. We had there were people from Inspire in the room and people from Zoll Respicardia for the activation, and it's remarkable. And this gentleman, it's like 6'6", so you can imagine he's got big lungs. But when we stimulated, you could hear, I kid you not, you can hear the lungs inflate. It's like a vacuum effect. It was really, really neat. Now, in general, people tolerate it very well. There is a learning curve to it because some people can get referred pain, right? If you irritate the diaphragm, overstimulate, you can get referred pain on the ipsilateral side. So there's a little bit of that, but in general, patients tolerate it quite well. The first, I'd say 4 to 8 weeks, there's a learning curve because we set the outputs quite low and gradually step up, right? Just like how we do with Inspire, we start at low voltages and gradually build up. Same thing with the Remede implant as well. Individuals that have more sensitivity to the stimulation are going to be folks with a history of chronic pain syndrome. Those individuals, we've learned, can be a bit more sensitive to the stimulation. They still end up doing well, but it just may take us longer than that typical 3-month window to get them titrated. We just have to go slower on increasing the outputs to allow them a bit more time to get adjusted to the stimulation. It's not painful. It's just a different sensation of having your diaphragm, stimulated to contract when you weren't, prepared for it, so to speak, especially if you're awake. But they do really well. People with high anxiety can also have kind of a similar phenomenon. It just takes longer. But so far, I'd say in all of my patients, it's been 100% effective, meaning that if their central AHI was 30 and above, we've been able to get them down to less than 5, many of them to 0, right? And it's intuitive because if the device is meant to constantly stimulate breathing, then why wouldn't it overcome?
Yeah, you can't stop breathing, basically. We should have a good response.
You can't. So,
I have one more question about it that I was really curious about because one of the struggles that we all have as sleep physicians ends up being the patient who has what we call a cardiomyopathy. Now, there's different kinds of heart failure. What I'm focusing on is something that Ruchir had alluded to prior, which is that the heart muscle, the left side of the heart, doesn't squeeze very strongly, that it becomes weaker. And we call that a systolic cardiomyopathy, also referred to as congestive heart failure. And that's the classic form of congestive heart failure. And that ejection fraction means how much blood is able to be pumped out with every beat of the heart. And when the ejection fraction stops being able to beat sufficiently, we can start to see people have breathing patterns where they can start to, it's really the heart failure that causes the central sleep apnea, essentially. And so my curiosity with it makes sense that back in the day, they tried a trial. They thought, okay, great. We have this new mode of ventilation, the adaptive servoventilation, or ASV, that you had described, Ruchir. And we initially thought, hey, we've got a treatment for central sleep apnea. Hot dog. This is good. And then what ended up happening is we're like, oh, that's not so good in people who have really weak hearts. Can you explain a little bit about what the thought process was about why non-invasive means like ASV are not good for that patient population, and what you've seen in that patient population who have the Remede device? Because it's so neat that a group that otherwise I couldn't do anything for, I now have potentially a treatment option for.
Yeah, I mean, so it was the SERVE HF study, right, in 2015, right before the sleep conference. I still distinctly remember this. It was a ResMed trial, I believe, that resulted in early termination of the study because there was an increased, mortality rate in the patients with this same type of heart failure that Allison described, where the heart was pumping less than 45% of the blood that it was receiving. And there was a higher rate of mortality in the patients using what we thought was supposed to be a fantastic treatment for them. And long story short, and there was a newer study, I think, by Phillips recently, right, in the last few years, I believe it was called Advent HF, that didn't have,
I think so. Yeah.
Didn't have that same output. So it looks like there's an algorithm difference between ResMed and Respironics, the ASV devices, and there's something about the ResMed algorithm, without getting into too much detail, that may have resulted in that increased mortality rate. So for all these years, like we've been for 10 years now, gosh, we haven't been able to really utilize ASV. Now over the last 5 years with Philips off the US market, we're only currently allowed to access ResMed's ASV, but we can't use it. There's a black box warning in this specific patient population. So it's been challenging to treat them. And the alternative, which is bilevel PAP with the backup rate, which I mentioned earlier, it's been around for a long time, but it can be a bit difficult to use.
Not working these people. No. I mean, I've used BiPAP with a backup rate in other groups of people,
sure.
But this group, I really thought it had something to do with the fact that you're kind of pushing air in, and somehow maybe that's changing the cardiac output in some way to these sensitive hearts that can't beat all that strongly.
Yeah.
At least that's kind of what I understood theoretically. I'm not sure if that's actually the case or if it's just, like you said, more of an algorithm issue.
Yes, I've read both things. I've also read what you're suggesting, where maybe the hypercapnia is actually cardioprotective in that patient population. And I've read that as well. But with this Respironics funded study that was published in the last few years that actually didn't have negative outcomes using the Respironics ASV in this patient population, it then also begs the question, like, is it cardioprotective? Should we not be treating these patients, or is it an algorithm issue, right? So I think there's still a lot to debate out there. I don't think anyone truly knows the exact reason, at least if I haven't come across it yet. But needless to say, we have this great option with Remede therapy where this patient population actually can be successfully treated, and it's actually improved outcomes. Like I have several patients with systolic cardiomyopathy that were having significant fatigue, and they were medically optimized, right? Because one of the treatments, right, for central sleep apnea and change Stokes respiration in the setting of systolic cardiomyopathy is medical optimization of the CHF. So
we don't do it we don't just implant people. You got to do the medical stuff first. Yeah. Good point.
You medically optimize these patients. And if they still have the central sleep apnea, well, then we have to treat, right? Because these individuals often have significant hypoxia, which in turn has a negative effect on cardiac function, brain function. They're exposed to, increased risk of stroke, so forth. But they're doing well. Like I have a gentleman right now who has systolic cardiomyopathy. He's got a left ventricular ejection fraction of like 15%. He has an AICD. That's a
defibrillator, guys.
Defibrillator on the left anterior chest wall. Then he has Remede for central sleep apnea. And he also has severe obstructive sleep apnea. So he's got Inspire. So he's got 3. And I've got many of those cases where they've got pacemaker or defibrillator and then Remede, Inspire. Plenty of real estate on the right chest wall for both to lay next to each other. It's too bad I should have sent you an x-ray of one of my patients that has all of them, but it's a neat x-ray to be able to see how they lay next to each other and where the electrodes are. But he's doing well. Like his quality of life has improved dramatically. He's very happy. His wife is very happy. I just saw him, I think, 2 weeks ago. And he's like, I'm sleeping well. I wake up rested. I still have a little bit of fatigue, which is felt to be cardiac in nature, cardiac fatigue, but he's like, I feel so much better. And he's in his mid-70s. Like his quality of life has improved, right? So from that standpoint, it's been a game changer for him because he couldn't tolerate PAP therapy. And it wasn't even because of his, his EF. Like even because I had offered CPAP therapy plus Remede. And he's like, Doc, I have severe claustrophobia. I couldn't tolerate it when I tried it years ago. I said, okay. I said, I'm not going to torture you by forcing you to try it again. We can go down the path of a third implant if you're okay with it. And he's like, whatever I have to do, I just want to feel better and sleep better and enjoy my life. And very, simple procedure and doing well. So I have, I think 13 or 14 patients right now with both implants. I have the largest number in the world. So from what I've been told by Remede.
Wow. But 13 implants and having the largest number in the world just shows you, to the listener, that this is new. Yeah. But here we have someone who is willing to go out on a limb and explore these possibilities. And I hope you're intending to publish some of this information, because if you've got the largest population, we gotta get some data here. I think this is really cool. I certainly have had a bit of that reticence as you described with Inspire, just thinking about, I'm like, would I really implant someone who, and it sounds to me like I may have to rethink being a little nervous about referring them for implants. I think they're starting to do them in New York now. So it's just some fascinating stuff.
It's a cool time to be in sleep medicine, right? Honestly.
Absolutely.
Apart from Apple Watch and Samsung be able to suggest that, hey, you may be having sleep apnea, right? I mean, come on, let's just call it how it is. That's neat, right? That now consumer products are able to kind of guide patients towards optimizing their health. But even for us as clinicians, and mind you, I am a bit of a unicorn in the sense that I kind of delved into neuromodulation and sleep apnea, but then I'm also a brain stimulation specialist with my TMS clinic and transcranial magnetic stimulation. So I've for the last 6 years, I've really gone deep into this rabbit hole of neuromodulation, but I really firmly believe that it's the future of medicine, right? I mean, even vagal nerve stimulation, like one of my companies, we have a transauricular vagal nerve stimulator for insomnia, but also for cognitive functioning and ADD. It's an amazing world that we're slowly kind of delving into as a field in medicine in general. But I think in sleep medicine, it's a major paradigm shift for us to go outside of PAP, right? The easiest thing for us to do is sleep apnea, PAP, sleep apnea, PAP. Like we weren't trained to be PAP specialists. We were trained to be sleep specialists, right? And we really should force ourselves to become uncomfortable and think outside the box for our patient, right? We all keep educating our patients that untreated sleep apnea can cause atrial fibrillation, heart failure, heart attack, stroke, dementia, Alzheimer's disease, premature death. Okay, we all know what the long-term risks are. If your patient can't tolerate PAP, then why in the world not consider these other really well-proven therapies that, fine, they're implanted, but ask a patient. Like I've met a lot of physicians that just assume, and I have physicians in my own practice who just assume that their patient would not want something implanted. It's like, but did you actually broach the topic or even discuss it? No, I don't feel that I don't feel that they're ready for having an implant. It's like, but how do you know? Like, why are you making the decision for your patient without asking them? Like, ask the patient. It's been rare that I've had a patient not want to move forward, right? And I'm not there trying to convince them to it. I mean, these are patients where I really don't have any other option left, right? They've tried PAP therapy, they've tried invasive device therapy or oral appliance for sleep apnea. They're symptomatic. They've got medical comorbidities that is being impacted by the untreated apnea. They want to feel better. They want to improve their quality of life. Like, okay, well, you've tried everything else. We've got this great therapy here, but it is an implant. It's invasive. It's an outpatient surgery. Quick recovery for both Remede and Inspire. It's the same. What do you think? Like, if it's going to help, let's do it. But the key thing is education and setting expectations, right? I think that's one of the other things that some providers may not be fully doing, is setting the expectation of this therapy, especially both of them, right? Both of them take time, right? I mean, just to get into the surgeon's office or the EP's office may take a couple of months. Then the surgery, the workup, actually for Inspire, we have to do drug-induced sleep endoscopy and then scheduling and then healing. And it can take, a few months before it's even time to activate the implant. And then after we activate, for both, it can take an average of 90 days to be able to get, successfully titrated. In some cases, for both, it can take longer. But patients often come in not understanding that it's a marathon rather than a sprint. And I think as a field, we have to make sure that we're setting these realistic expectations. I've had some patients with Inspire that it took me 2 years to get them successfully titrated. Now, it's rare, but it happens, right? And I didn't give up. And we learned a lot of things. Myself and my ENT partner, we learned some fascinating things last summer about patients, especially mouth breathers. I'll just share it with you. So mouth breathers with Inspire, we've observed through DICE with Inspire On that the tongue base actually doesn't move. The tongue base will move even with stimulation with Inspire if the mouth is open. So that's one of the things that we learned. And for this one case, like I said, it took 2 years. We tried everything. I did a lot of advanced programming. He felt better. He felt better pretty quickly in the process, right? So it wasn't that he was symptomatic this whole 2 years. Felt better, was sleeping better, but I couldn't get his AHI down even by less than 50%. He was still hovering in the mid 40s and he was still hypoxic in the high 70s. So it was really objective improvement that I needed to get him to. And did advanced programming. We did an awake endoscopy. And then at the end, I even did a mandibular advancement device, combination therapy. Still couldn't get his AHI down. So I told my ENT partner, I was like, let's look under drug-induced sleep endoscopy with Inspire to see what is going on. Like, let's see what's happening when he's asleep. And it turned out he was sleeping with his mouth open. The tongue base wasn't moving. Close the mouth. Boom. The tongue base was moving. And Thomas Jefferson, so Thomas Kaffenberger and the Thomas Jefferson group published a paper actually troubleshooting upper airway stimulation with DICE last year. And it was cool because what they published actually validated the things that we had discovered ourselves. We were like, oh, awesome. Yeah, this is great. But all we did was added a Chinstrap.
Oh my goodness.
I'm not kidding you. Allison, I'm not kidding you.
These things are like $10 online, not even. Something as simple as that.
That's my go-to. But literally, just by adding a Chinstrap for this one patient, his residual AHI went from 48 to 23. Same programming, same home sleep apnea testing device. Same. Everything was the same. So I made sure there were no variables because I really wanted to see what was the impact of just keeping his mouth closed. And then I titrated his amplitude, brought him in the lab in January. His residual AHI is 12 now. And his baseline actually started at I think.
Wow, that is such a cool story.
We have several of these, right? Where, several meaning like probably half a dozen, where these cases in any other traditional sleep office probably would have been told 6 months ago or 9 months ago that, sorry, Inspire won't work for you, right? And they would have been said, go get it taken out, or it would have had a negative view. I'm that guy that just won't give up, right? Like, we got to get this figured out. Like, there's something else that we're missing here. What is it that we're missing? And my ENT partner, fortunately, is the same mindset as well. We're both nuts in that respect, but that makes us a great partnership.
This is a good kind of nuts, guys. I'm so impressed right now. Yeah. This is really cool.
I have another patient that I actually had different ENT partner. I had her undergo DICE twice with upper airway with Inspire. The first time around, we discovered that she actually had a complete concentric airway collapse. Oops. Probably shouldn't have been implanted, but she was. Ended up undergoing modified UPPP, still had difficulty tolerating stimulations, kept having disrupted sleep, did an awake endoscopy, electric configuration change, advanced programming, did another DICE. I said, look, she's still struggling. Now we're over a year now, and we've already done upper airway surgery. We've corrected the CCC, the complete concentric airway collapse. I want to do another DICE with upper airway stimulation. Again, mind you, this is another ENT surgeon that's not as experienced as my main partner, but I said, let's do it. Did it in February. Turns out mouth was gaping open. And what do we do? Close the mouth and boom, the tongue base was moving, right? At the same programming. And then literally I did a study on her. Her baseline AHI was again like in the 30s, brought her down with a Chinstrap. She just had her study done end of April. And her residual AHI is like 0.9.
Nice.
Through the night. And she just messaged me through the patient portal on Monday last week or Tuesday this week, I can't remember, saying, Dr. Patel, just want to give you an update. I am sleeping so well. This is the best I've slept in over 20 years. Thank you. She goes, it took time, but thanks for the effort and thanks for being persistent. This is amazing, right? And she was ready to get it taken out. And she was ready to even go to BiPAP. Like, she had been treated with CPAP multiple times in California. No one had even talked to her about BiPAP. And mind you, I met her after she was implanted. She was implanted and then sent to me, right? So if I'd have met her first, I probably would have talked to her about a trial of bilevel PAP. And she was a thin woman, normal BMI at 23, 65 or 64 years old when I first met her. But we troubleshooted it, and she's got a normal AHI, and she's extremely happy, right? She was on the verge of getting it removed. And I said, no. So let's try one more thing. And what I suspected at the end was like, I really think your mouth is open. Let's do a DICE to verify. And sure enough, it was. And Chinstrap, ruby red Chinstrap.
Oh man, I've totally recommended the ruby red.
Yeah, it's a good one. It's a good one.
So good.
No, but learning.
What a small, I've what a small world in terms of so many parallels with this. Yeah. And you've given me hope about implantation in a way I did not otherwise see it. So I really appreciate you taking the time to speak with me.
Yeah.
And I look forward to seeing you at Sleep 2025.
Absolutely. You're going to be in Seattle?
Yeah. Oh, heck yes,
Awesome.
I will. Awesome. I'm sure I'll be running into you.
Absolutely. Thank you, Allison. This was great.
Struggling with sleep? Dr. Cole is here to help. Whether you need a comprehensive sleep coaching program, suspect you have sleep apnea, or simply seeking a second opinion, she's available for consultation in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 10-minute review of services today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted sleep expert.
Please be advised that the Sleep is My Waking Passion podcast is for entertainment and educational purposes only. It does not constitute medical advice. Always consult your healthcare provider for personalized guidance. For my full disclaimer, please visit AskTheSleepMD.com. And while you're there, don't forget to sign up for my free newsletter. Sweet dreams and happy listening.